Hello, everyone. My name is Kristen Hobbs, and I'm a Senior Project Manager for Quality Improvement and Equity for the Center for Sustainable Healthcare Quality and Equity at the National Minority Quality Forum. I'd like to thank all of you for being here to join us today to talk about vaccine disparities, ending the real barriers in communities of color. Now, before we get started, I'd like to take care of a few housekeeping items. We know that you will all be eager to answer questions or ask questions, of our esteemed panel today, but please wait until the Q&A portion to ask your questions. And if you could, please place those questions in the Q&A box, not the chat box. We don't want your questions to get lost amongst the chatter. So today's session will really probe the factors contributing to vaccine disparities in communities of color, including at the patient, provider, systems, and environmental levels. Now, we want to really move beyond simply talking about vaccine hesitancy, as it is specifically assigned and uniquely assigned to people of color, but really probing issues of access, provider trust, barriers to vaccination, and systemic racism. We seek to answer these three questions: what factors contribute to lower vaccination rates amongst people of color? What strategies can raise these rates among Black and Hispanic Latinx populations, and what you can do to help? And with that, I'm delighted to introduce such an esteemed panel today. We have Dr. Matthew Kusher with us, a family physician and clinical director at Plaza del Sol Family Health Center and Urban Health Plan. We have Ms. Lois Privor-Dumm, director at the International Vaccine Access Center at Johns Hopkins University Bloomberg School of Public Health. Dr. Stephen Thomas, professor and founding director at the University of Maryland Center for Health Equity, School of Public Health. Dr. Patricia Whitley-Williams, professor and chair at the Department of Pediatrics at Rutgers RWJMS, and Ms. Lathryn Woodard, Chief Executive Officer at South Carolina Primary Healthcare Association. So thank you all for joining us today. And I really just want to dive right into our discussion, if you all do not mind. First, I'd like to ask a question of all of the panelists, starting with you, Dr. Whitley-Williams, and then everyone please chime in afterwards. What role does vaccine hesitancy or a lack of vaccine confidence play in lower vaccine uptake in communities of color and subpopulations?
Yes, good afternoon. Thank you so much for that question. Lack of vaccine confidence plays a major role in lower immunization rates in the Black community. This is due to, I think, a large part, mistrust of the healthcare system. It's not surprising, is it? There's a long history of racism in this country, including the healthcare system. And there's a long history of exploitation and medical experimentation. We always talk about the Tuskegee syphilis experiment, but there are many, many more, including forced sterilization, et cetera. So it's very easy to understand why there would be mistrust. Black patients also are subjected to stereotypes, even visits to healthcare facilities, emergency rooms, admitted to the hospital. So we have to remember that trust is earned. Trust has to be earned. And as healthcare professionals in the healthcare system, we need to be aware of that and learn how to build trust within our communities by listening and engaging with people in the community. National Foundation for Infectious Diseases, of which I am a member and also president, had done a survey of Black adults and found that 68% of Black adults age 60 and older plan to get vaccinated with the COVID-19 vaccine, but only 43% of people who were 45 to 59 years of age were willing to get vaccinated. So that's interesting. The older Black adults were more likely and more willing to get vaccinated, but not so much the younger population of adults. And so I think these are important things that need to come into play as we carry out certain strategies. And I'll stop there.
Absolutely. Ms. Lois Privor-Dumm, would you like to chime in?
Yes, I'd love to. And thanks for having me here. Dr. Whitley-Williams brought up a lot of really good points. And I think one of the things that we have to remember is that there's a lot of diversity in the population. And there's no single group that thinks the same way. We also have to consider what we mean by hesitancy. And in some ways, you know, I almost wish we didn't use that term, because there's a continuum. There's people that simply have a lot of questions, and that promotes a good dialogue. It promotes questions, it promotes interaction with health providers, it promotes conversation with those that are working with public health. So it can be very, very healthy. And sometimes a little bit of what we may refer to as hesitancy can be a very good thing. The other thing I think we need to remember is that it's a very dynamic process. So it depends on where the person is in a place in time, what issues are of concern at a particular point in time, the levels of priority in their particular lives. So there's a lot of different considerations. One of the things that I thought that was important that she brought up is also age groups. And what we find is we're working with a number of different populations, and there's a big difference between older adults who may have a lot of underlying illnesses and concerns about disease, and young Black men, for example, who often are thinking about, well, how am I going to get to work? What happens if I can't get time off? Or I'm concerned about police brutality. I'm not concerned about this. And we have some very, very different ideas. So hesitancy means a lot of different things to a lot of different people. And I think when we're dealing with hesitancy, our responsibility is really to understand the context of the people that we're talking to, their issues, and really listen to them to a point that we're hearing what their concerns are and addressing those concerns, which may or may not be about the vaccine.
Absolutely. Dr. Thomas, did you have some insight to add there?
Well, I love this conversation, and but it makes me ask myself a question when we should all be asking: why are Black communities being singled out as vaccine hesitant? Positioning distrust as a problem specific to African Americans is not only inaccurate, it's unjust and it's harmful. What's interesting? It's like they moved a cheese. We've been working for decades to address the health disparities, to improve diversity of underrepresented minorities in clinical trials. We've made some progress in overcoming the legacy or the shadow of Tuskegee. And here we are finally getting Black folk ready to sign up. And they say, before I roll up my sleeve, hold on, let me make sure that you can answer my questions. And when they ask the question, will the mRNA vaccine change my DNA? Don't shame, don't blame, just listen and answer their questions. We've seen these town halls move people from hesitant to, actually, you want to tell the truth? You see my barber pole? They've moved from hell no to maybe, and from maybe to where do I sign up? And from where do I sign up? Why is nobody calling me back? And now that vaccine is available, Black folk are lining up because they're bringing vaccine to the Black churches. They're bringing vaccine right to the neighborhood. And yet the front page story is Black people are hesitant. I think it's a cheap shot because it's too simplistic and it's being used as the reason for the inequitable distribution of the vaccine. That happened right here in the state of Maryland. where an elected official said, well, the reason why white folks from other counties are going into the Prince George's, majority Black county, Matthew, getting vaccine, is because Black people are hesitant and we don't want to waste anything. That was not true then. It's not true now. So let's not let it be used as a smokescreen. The fact of the matter is that we have large segments of the white community, not just hesitant, but anti-vaxxers. That's not the situation with Black people. They're not out, demonstrating and trying to shut down vaccine sites. Isn't that interesting? That has not been our community, and yet we're the ones portrayed as hesitant. I think it's wrong. We need to use the language in our communities of vaccine confidence. And there's that continuum, Lois. One can be highly confident or just a little bit confident or not confident at all. That's a different frame, because my confidence is a function of how you present it to me. My confidence is a function of how easy is it for me to access. Hesitancy puts it all on me. And I think that is not fair because it ignores the system that is broken.
Absolutely. You all three bring up excellent points, especially this continuum of confidence. And I'd like to have Dr. Kusher really comment on the question and also that continuum of confidence for the population that he serves.
Good afternoon. So I think what we need to think about is what Dr. Thomas was alluding to, which is there is questions of also access. So we still think, oh, everybody has access to the vaccine. That's not true. That's not true as of yet. I will tell you that this week, just yesterday, we opened up a vaccine center in the community that I serve, which is Corona, Queens, New York, which we were the epicenter of the coronavirus epidemic in the start. We still are not vaccinating very much our community, not because people don't want the vaccine, but because people don't have access to the vaccine. Because it is challenging to make appointments on the internet, because it is challenging for people to feel safe to go to these mass vaccination sites where there's police and there's Army and National Guards folks. And they might not feel, as somebody who might not be here with the proper paperwork, that they should be going to such a place. So we opened up a place here at the local church, which is the most trusted place in the community. And so people are lining up, like Dr. Thomas was alluding to with Black churches. People want to go where they're safe. People want to go and want to hear that this is the right thing to do. What patients ask me is it safe? Should I do it? And when I say yes, they're like, okay, that's what I wanted to hear. I'm ready to do it now. Where can I go? And up until last week, we had very limited places of where they could go because they don't necessarily speak English. 90% of my patients do not speak English. They speak Spanish. And so trying to go somewhere is not so easy. And so instead of saying, oh, they just don't want it, like the other presenters were saying, it's not a matter of that. It's not so simple. It's really, unfortunately, not. But people really are looking for trusted voices. Mm-hmm. It has surprised me that politicians, people really look to them. Over the last years, I really thought that wouldn't be something that was a thing, but it is. When I gave AOC, Congresswoman AOC, her flu vaccine the last 2 years, and people really, they like that. They said, oh, AOC got her vaccine, maybe I should get it. I was very taken by that because I didn't think people would care. And people really did, because they want somebody that they feel that they can trust and is relatable to them to receive it first and to do it. And
Absolutely. I think really developing those relationships, as another presenter in our previous session talked about with the gatekeepers in our community, whatever level they're on, is key to making this work. Ms. Lathrun Woodard, I'd also like to get your perspective on this topic and how you see it.
Yes, thank you. And I appreciate everything everyone said. I don't like the word hesitancy. We've been using that. It's so many facets of it, but I think that the people, I'm gonna say of color, but not just people of color, everyone is cautious. Don't mistake me being cautious and wanting to find out more for my not wanting it. So I've had people run into, and I deal with real life situations of, and this goes past socioeconomic barriers too. I had people, not Tuskegee, they weren't talking about that. You know what they were saying? I followed and paid attention to the FDA process of how do you get vaccines through. Now, yes, they went through every step, but that last step was too short. They didn't do clinical trials long enough so we could see if something gonna happen. I mean, that's not saying I don't want it. To me, that's the intellect of the person of saying, before I do anything, I'm gonna check it out. That doesn't say I'm not gonna do it. The other point is access is a big issue, which has the appearance of hesitancy, if you will, or not wanting it. And that is not just having someone to go to trusted, but the process of filling out applications. I don't know whether y'all tried it. I just stopped it. And I work with a lot of seniors. In case y'all don't know, elderly is not the correct word anymore. We are called seniors, okay? And trying to fill it out. And I have a 95-year-old mom lives with me. And one of the things they ask for is an email. My mother doesn't have an email account. And so we started making up email accounts, helping people to fill it out. And even households who had an email account, if there's 2 people living in there, you couldn't use that for one person. Okay, this is ridiculous, okay? So you have people that just stopped because they got frustrated. So, and then you also had the, I think it was Lois saying, other priorities. Okay, number one, I have other chronic illnesses. I am sheltering in place. I am worried about my, whether it's diabetes or whatever, hypertension. I don't want to go out and get exposed. I don't want to go out. Okay. So they appear they're not accessing it, but it's because it's not accessible to them is why they're not accessing it. So we have to really look at this. And then someone said also, when you look at people who are not getting it, it's not just the people of color. I target the people of color because when the vaccine came out, they were having a lot of access issues, and we needed to help them with that in terms of, especially in rural South Carolina, getting to places. We have FQHCs in some areas, but we had to actually go out to, I remember the old days, going back to basics, where we sent out community health aides, nurses to homes, so people felt safe to get the vaccine. And then the last point I want to make is reality check. There's still a lot of people not taking the flu shots. Are we talking about them? Okay, so yes, the vaccine is important. And then you also have a lot of misinformation that's being put out there. And it's up for us to educate, and from a trusted source. You heard of, it's not just the message, but the messenger. So for our health centers, what we've actually done, and sometimes, Matthew, that it's not the provider that's going to be the trusted one. It's, I like you now, but wait a minute, you know, I don't care if you do take it, but it may be a front office staff person. It may be a barber. It may be someone else. We have a tendency to just group everybody together and say, this is the answer. It's not. My reason is different from yours. And we have to, just like we do medicine and you do individual assessments on patients, we have to do that with the messages we take and who's taking a message. So those are my 2 cents in terms of what I see with the vaccine piece. And, you know, there's still some lack of trust of these big mobile units, and nothing against the hospitals. These hospitals have bought all these mobile units going into these rural areas, and these rural people are saying, who are you? And the other question they ask, what if I get sick? You're not here in this community, what do I do? So let's be real with this. And it's not making it look so negative on communities of color, our rural communities. Look at exactly what's going on as to why they seem to be in the lower numbers of getting vaccine, but also in the higher numbers of death rates.
Absolutely. You all mentioned some great points about the continuum of vaccine confidence, and also about those targeted and prioritized messages that we need to funnel through our gatekeepers. And so I really appreciate you going into the other important factors that really contribute to the barriers for individuals just wanting to have questions and wanting to have those questions answered before they even sign up to get a vaccine, and all of the barriers in technology and that digital divide, and rural and transportation, and Ms. Privor-Dumm, like you mentioned, police brutality. Folks are really concerned about a lot of things. And so I really want to shift our focus now to understanding solutions for that. And Dr. Whitley-Williams and Dr. Kusher, I want to ask you this question first. Since you are clinicians, what recommendations do you have to actually address this continuum of vaccine confidence and really improving that vaccine uptake in communities of color?
Certainly, absolutely. Thank you for that question. There are several things we can do. You've heard the other panelists talk about listen. We need to partner and collaborate with community-based organizations to get their expertise and how to allay any concerns or fears or myths that they may have about the vaccine. I think that's very important. As an example of that is partnering with faith-based organizations. My own church did that and had 3,000 doses. And within 2 hours, people had either called or signed up online. 3,500, we only had 3,000 doses. So I agree, it's not always a matter of people of color not wanting to get the vaccine, but again, really wanting to make sure that they had all their questions answered. But many of us were willing to get the vaccine as it came out, but could not access it. I think another example of within the community is the younger people helping the more seasoned people or the seniors. And that's exactly what some communities have done, is to use younger people who are more facile with computers and signing up some of our seniors to actually get the vaccine. So that's one thing. Secondly, we found that it's important. I'm a member of the National Medical Association, which is a national organization of Black physicians. And early on, many of those physicians, our membership, had serious questions about the vaccine and expressed some of the same concerns as people in the community. So one would be, first of all, the vaccine seemed to be developed very quickly. So were tight controls, were all the rules followed in terms of clinical trials and getting this vaccine to where it was approved for emergency utilization? The second concern was, if I get, and similar to flu vaccine, if I take the COVID-19 vaccine, am I going to get the infection? That's a common thinking amongst not just people of color, but all people. And then third, I had to do with being concerned about some of the side effects. So I think there are many people of color who trust their physician in the community. And yet, if the physician is concerned about a vaccine, early on, there was a lot of concern about the COVID-19 vaccines to their patients. But so the first thing we did was to try to educate our membership and make sure they had access to information about the clinical trials. There was also a fair amount of pressure, I would say, or concern to make sure that people of color were represented in those clinical trials. Unfortunately, the percentage was not as high as we would have liked it, but I believe there were 10% representation of Black Americans in the Pfizer trial, and maybe 13% in the Moderna trial, a little bit higher, but that only happened after a huge push so that we would have a better representation. After all, we don't want to use a vaccine or a medication that has not been, at least in which a trial where we have not participated, to make sure that there would not be any untoward effects. So I think that's as a healthcare professional, to make sure that we're educated and we can answer the concerns of our patients, who will then come to us and ask, what is it they should do? And then to make sure that we're represented in clinical trials, so we can with confidence say, the rules were followed. In fact, the messenger RNA vaccine that's out there, that process had been in development for 10 years. In fact, some people don't realize that that's what the Ebola vaccine was made. It's exactly the same process. It has been in development for many years. So I think it's important for physicians to understand that, to make sure they can explain that to their patients. And then the side effects. We're all concerned, obviously, about side effects, particularly with any new medication or new vaccine that has been made available. It's important for us to realize that there are safety systems in place, not only the pharmaceutical companies that have developed the vaccine, they have what's called a post-licensure, or I guess in this case, we post-emergency utilization authorization, to follow some of the patients in their clinical trials to see if there are any long-term effects. But there are also at least 4 other safety systems that are out there to monitor. So you've probably recently heard about the blood clots, or the thrombosis. That would not have been picked up that readily or that early had it not been for these safety systems. So I think it's important for us to understand that there are these safety systems, and there is an ask of the pharmaceutical companies and also of these safety systems, that we make sure that we do continue to look if there's any untoward effect on one ethnicity versus another, or by gender, and women more likely to be susceptible of this rather than males. So it's important to continue that. So those would be some of my suggestions as a healthcare professional. And above all, listen to your patients, listen to the community, what they're saying, become partners, as was done in collaborating with faith-based organizations or with community-based organizations.
Thank you, Dr. Whitley-Williams. Dr. Kusher, I'd definitely like to hear your perspective on this as well.
So what I think is interesting is when we talk about from the individual level, how do we connect with that patient? How do we overcome any resistance that there might be? And it's really to be honest and talk about the risk and benefits. We know what the risks of COVID are. At the end of the day, the risks of COVID are death or being a long hauler, things that are clearly unpleasant, right? What are the risks of the vaccine? Of course, there's risks of the vaccine. And we need to be honest about the risks of the vaccine. I got my vaccine. I felt terrible. And you know what? It didn't matter. I knew that I wasn't going to die from the vaccine, and that overall, my chances of being able to be protected are important. And so that's what I talk about with my patients. I say, I felt bad from the vaccine, and that's okay. And it's okay that you might be worried that you're going to feel bad from the vaccine too. And you might. You also might not. But the risks of actually contracting the virus and becoming sick with the virus is much worse than the risks of feeling not well for a few days. And I understand that they feel, well, maybe I won't feel any side effects from the virus. The problem is we don't know if you will or not. You might be a healthy person, a 25-year-old person who, after 3 months after contracting the virus, you still might not feel well. And we have a lot of those. About 10% of people who contract COVID are what we call the long haulers, people who continue to be sick from weeks, if not months later. And so when we talk more about that, when we really delve into the risk-benefit ratio, unfortunately, there's really no alternative than to take the vaccine. I had my doubts. I will tell you, I agree with Dr. Whitley-Williams. I had my doubts about the vaccine. I was hoping that it wasn't going to come to us so quickly. I thought, it'll go to the hospitals first. I'll have my chance to wait. I didn't have my chance to wait. And I made the decision based on that risk-benefit analysis that this is what I just needed to do. Because at the end of the day, we don't really have too much else of a choice to protect ourselves, protect the community, At the end of the day, that's where we're at, because there is no medicine, and no medicine is coming to save us from COVID. It's not going to happen. So we just need to really be honest about the fact that, yes, there are side effects, and that's okay. And it's okay to talk about the side effects as long as we recognize that those side effects are less severe than the risks of actually contracting the virus and being sick.
Absolutely. Being transparent about that risk-benefit analysis is extremely important. Ms. Privor-Dumm and Ms. Woodard and Dr. Thomas, I'd like to ask the same question of you guys as healthcare leader, community leader, researcher. How do you feel, and what are your recommendations for really addressing that vaccine hesitancy in your communities, and as you see it as researchers and community leaders?
So I have a few thoughts, and one of the things that I think we have to recognize is that we're actually at a different place for a number of people, because a lot of the people that really want the vaccine and have been trying to get the vaccine, have already gotten it. There's still many that still haven't received it, but we're starting to deal with populations that are fatigued. They're tired of all you ever see on the news every single day is something about vaccine. Well, people have other, goals in life, and our goal should not be, the default that you are going to get a shot in the arm. And I know that's not necessarily a popular stance in this particular forum, but I think one of the things that we have to also be thinking about are the longer term goals, which are to make people feel comfortable in the healthcare system, to have them really understand the decisions that they're making. And in some ways, I think we have to have a little bit of patience and learn to treat people with respect, because different people view the issues in very, very different ways. And it's a tough thing, because we feel like we know what the exact answer is, and we want this to particularly happen, but you have to build ownership. You have to get people to recognize that, this is the way that we're going to get to something that we want, not something that somebody else wants. Because there's a lot of people out there that actually don't fear death, or they don't fear some of the things that the illness and hospitalizations. Again, they may be very young and healthy and think, well, I'll just take my risks, and I'm not going to put something in my body that possibly could cause me harm. So, whether we agree with that or not, I think we have to listen, and I think we have to show that we're paying attention, that we understand that sometimes people's goals are things like, I want to get back to school, or, I want to be able to go out to restaurants and, play sports and live life like I did before. And getting them to recognize, what is a world if populations and communities aren't all vaccinated? Well, the reality is that governments are going to continue to shut things down. But it's a matter of shifting the conversation in some ways to the needs of a particular community, and understanding that at different points in time the conversation is going to be different. The other thing that I think we also need to be doing is taking this broader view and setting up for success. I've been working with churches quite a bit, and it's amazing how many people come out for vaccines. Well, this is also an opportunity to provide information about housing, information about testing, information about where you can get food, or handing out food, or distribution of various services, and directing people to where they are, because these are all things that build trust. And if we can start to think about how we use communities to be able to be part of the solution, not everything has to go to a health provider immediately. There are some intermediate steps. And if we could start thinking about some of those policies or enabling processes that get people to take ownership of their health, I think we'd be much further ahead.
Absolutely, Ms. Woodard. Go ahead.
Okay, yes. I had to write mine down so I won't just go off. As first, I'm very spiritual, and I remember, we said the poor will always be with us. We're always going to have people who are not going to take the vaccine. Okay, that's just it. So, we need to concentrate on educating and those who are interested, but just not because they don't understand. Lois, I'm gonna do a different flip on what you said about they don't fear, especially the younger kids don't fear death. Well, I think they feel they're invincible in terms of health, not so much as, death per se, but I'm a healthy person. I have a 39-year-old nephew who I can't get to take the vaccine. He won't take the shot. I have a cousin who is a scientist who was working on the vaccine. I said, well, talk to him. That didn't work. So you have some people, we have to realize they're not going to do it. I don't care what you do, they're not going to do it. So I put those over here on the side. And then we have people who are looking at the workforce. We're having a problem in FQHC of our workforce taking the vaccine. We've gotten an uptake on that from, it was only 30%. Now we're up to over 70%. We still have our workforce staff who's not taking it. What do you think the patients feel if they say, well, you're not taking it? So that's another factor that we are working on. And then it's also a mental status for some people, a belief that you have two products out there that are 2 shots and one that's 1 shot, and not educating them on is one better than the other. Because if they feel they're getting the 1 shot, they feel, oh, this isn't as good. Is that what you're bringing to our community? So it's a lot of education. And don't think because a person didn't articulate in terms of higher education that they don't have common sense and wisdom. Okay, they know what they want. They'll understand if we explain to them. But we got to first understand, like I had to understand after I confronted the 1 shot people and they explained some things. And the last one for me is, and this is, I had hesitancy, okay? And my hesitancy was, how many of us was in that clinical trial? And I think it was Pfizer who said we had 20% people of color in the clinical trials. I said 20% people of color, define people of color. I wanna know how many African-Americans versus Latinx versus whatever. I said, that's not enough for me. So, you got people who have to ask questions and get past that feeling. So the factors are such a myriad of factors that we can't get frustrated as being part of the professionals that we are and explaining to the people, and don't get frustrated because they don't. Okay, just keep going back to them, giving them a chance to ask questions, whatever their questions are, and giving them the forum to feel safe to ask those questions and not feeling someone is going to say, oh, you're not educated, you don't know. So those kind of things are what I see us as community health centers doing, especially with our community health workers. They're going out there and doing some one-on-ones, and they're from the community, and people are trusting them and answering their questions and saying, okay, just think about it. How can I help you? What is it that you need to make you feel comfortable with it? I mean, did anyone think about asking that simple question? What is it that you need to make you feel comfortable? And then those are going to separate the people who are saying, I'm invincible, not going to want it, versus us getting people educated and taking it. But don't go out there to do that, and then they don't have a way to get the shot. They go stand in line. And I think it was Dr. Whitley-Williams saying, stand in line for however long and you run out of vaccine. Now, what's your chances of getting me to come back there and stand a couple of hours in line? So all those are things that I think are important factors that we need to address to look at getting an uptake in terms of vaccines.
Absolutely. Thank you for that. I think your point about making safe spaces is critically important, especially for millennials and Gen Z populations. A lot of what I do on social media, people will DM me on Instagram and say, I know this is a stupid question, but no, there's no stupid questions. I'm here to provide objective, unbiased information for you, and that's it. Dr. Thomas, what are your thoughts?
Well, my thoughts is everybody's being so nice. Uh, and if we don't recognize that we had 4+ years of nothing but toxic spewing of disinformation, that's not me making it up. That's the results of the national and international polls that the #1 source of disinformation, that means I'm consciously, actively trying to mislead you, was the White House podium. Who could have ever have imagined that? And you think in a few months, all that toxic environment's gone? It's still out there. And our communities were marinating in this disinformation before we got a new administration, okay? Because I've been out there on the front line. So I call it sacred space. Why is it we have to learn the lessons all over again? Did we not learn this lesson from the AIDS movement? This window behind me, that wasn't how the AIDS movement started out. It ended with this kind of thing, but it started out with discrimination, conspiracy theories, all the things we're hearing right now. And I just submit to you that COVID has made me recognize a new sacred space, and that's the Black barbershop and beauty salon. So I'm a revolutionary here. I want to break the whole thing up. If COVID has exposed the brokenness in our healthcare system, now we really know it's a sickness care system, and that we have no railroad tracks to get the vaccine, as miraculous as it is, into the arms of our people. We need to fix these roads, these public health roads, this public health infrastructure. And so I think it's about sacred space, places that we can stay in routinely. And for me, the Black barbershop and beauty salon can be a new home for healthcare. You see this little device I'm holding in my hand here? This is this cell phone. There are diagnostic tools now that physicians and other clinicians have. You don't have to be in a hospital. You don't have to be in a clinic. You can be out in the neighborhood. And so I think that if there's anything for Black folk to recognize, they were going to let us die. We're going to have to save ourselves. I think that's the mentality we need, the mentality that we came out of the civil rights movement with. Because the media right now is quickly trying to move back to things are back to normal. We're 4 stories in, like 4 commercial segments in before I get a COVID story. 100,000 people dead and the virus surging. So I think we need to stay in our communities, our sacred spaces, the churches, the barbershops, and start demanding that the institution, and just because the institution may have a person of color in charge, they're still running an institution that is oppressive. They need us. They need us to make the system work right. I would never have imagined that the CDC could be sidelined and muzzled. I could never have imagined that Dr. Anthony Fauci would have to have security guards and threaten his life. Okay? So I think we need a greater sense of urgency. Because we don't take cameras into the hospital room, people don't see the suffering. So yeah, I think a whole lot of Black people ain't afraid to die because they know there's glory on the other side. Every funeral I go to, it's all about someone went home. But nobody wants to suffer. And if you share with Black people the kind of suffering that COVID causes, trust me, they want to avoid that. And they also want us professionals to give voice to what they're saying. When I went in, they were telling me off. They weren't telling me off because they were mad at me. They're telling me off because I'm coming from an institution that had abused them, misused them, mischaracterized them in the past. And so I'm just the one that's here. You have to take it. It's not personal, but we have to take what we hear back to our institutions. And so what I'm hearing is that, why are you here now? We've been suffering. You got all these reports. You can predict my life expectancy by my zip code, but you don't do anything to change the life expectancy. Those are the questions we have to ask. And I think we have to bring ethics into the discussion. The ethics of justice. Justice means that those who bear the burden of disease should not be denied the benefit. And that's what's happening. It's an issue of justice. So no justice, no peace. That cry works also in the context of healthcare. And we need to get with it, stop being shy. We in public health and medicine, we're not political. But look, when they turn our work into something political, we cannot just disarm ourselves. So how do we arm ourselves? We go into the community with influencers like our barbers and stylists, our clergy, and we begin to train them on how to use this technology. This Zoom is a game changer. Let's use it to organize. I've been able to bring my barbers together with top scientists. I would never have been able to do that in real life, under normal circumstances. But when Michael Osterholm is talking to Dynamite Mike the barber with dignity and respect, everybody's watching that. And they say, oh, Mike's question was a good question. Look how the doc treated him with dignity and respect. Where do I sign up? Okay. So I think there's things we can do. But if we leave these communities in the name of everything back to normal, we will have missed a tremendous opportunity for reimagining healthcare in this country. Yeah.
Absolutely. Thank you, Dr. Thomas, for that. Before we move on to Q&A, this was really an extremely robust discussion. I want to talk quickly about a couple of things that we have coming down the pike at SHC. So we do have a robust set of COVID-19 resources that we will be deploying through our Drive Toolkit. If you don't know, our Drive Toolkits are really tools that clinicians can use to improve vaccine uptake in previously flu and now COVID-19. And hopefully we will be able to improve quality in other disease states going forward. We also have a cooperative agreement with the Centers for Disease Control and Prevention. So everything we just talked about, we know about the disparities in vaccine uptake and other factors that are at play, the ability to get to a vaccine provider, trusted providers and trusted influencers and gatekeepers who are rallying for the vaccine, other social, systemic, and political determinants of health. And so what we seek to do with this cooperative agreement is identify, develop, distribute, and provide training for community leaders and providers to educate our communities of color about COVID-19 and flu vaccinations. And with that, we need your help, everyone that's watching us today, to become an NMQF Health Champion. Now, an NMQF Health Champion is really any individual who has the determination and the enthusiasm to address health and clinical issues in their communities to improve health and public health interventions. And these champions are eager and determined to promote equity in COVID-19 vaccinations in Black and Hispanic communities through culturally appropriate and culturally relevant communications, education, and training. Now, I saw earlier that my colleague, Dr. Laura Lee Hall, already put the link that you see on the screen in the chat box. So I'll go ahead and take this slide down as we segue into our Q&A portion. We have about 10 minutes left. Again, please put those questions in the Q&A box. Our first question, how can we help our younger men who seem to be less inclined to get the COVID-19 vaccine? Dr. Thomas, if you want to start with that one, and then anyone else can chime in.
It's funny. That's a very good question. So I'm going to take you right to the barbershop, and we're doing interviews in the barbershop asking, and there's diversity. There are people who've taken it, people who won't take it, people who are refusers. Talking to this young man, 30 something, he said, I trust my own body. He said, I trust my own body. I don't want to put anything foreign into my body. I'm going to trust my own immune system. I'm going to start eating better. I'm going to start exercising, and I'm going to go get a checkup. I said, Joe, I've been telling you that for the past 3 years. You ain't done a thing. And then we all break out laughing. And then I say, you know what? Let's meet him right there, because all the health promotion, disease prevention activities around type 2 diabetes prevention, he's now ready for that. That's the teachable moment for him. Not shame him, not blame him, meet him where he is. And now let's move him along. We're asking people to process a lot of information in a short period of time. So I'm happy with that. They want to be healthy. Let's ramp up our type 2 diabetes prevention, our health promotion and disease prevention activities, so they have a range of things to do. Now the vaccine is in context, and it's not some isolated thing. It's about improving your overall health. That's what I say.
Go ahead, Ms. Lois.
I think Lathrop had her hand up first. Why don't we go to her?
Yes, go ahead.
Thank you, Lois. Really quick, I'm going to talk about not just young men, but young people in general. This is my mission, is I am looking at training younger people to be ambassadors to talk to other younger people. Okay. I have a 25-year-old granddaughter who does her research, although she's the one that said when she was waiting until after Congressman Clyburn had his shot, she was going to wait and see if he grew a third eye before she, had hers. But she does her research. And I listened to her talking to her friends because she's gotten her shot. She's found out about people who have transplant. She talks their language. And I think we need to, not just in the space of COVID, where are our new up and coming leaders, for lack of a better word, civil rights leaders, where are our up and coming? Are we training them? This baby boomer generation, I think we've kind of dropped the ball, and now it's time for us to pick it back up to help train. We do have some, I'm not dismissing those that are out there, but I think training younger people to talk to people, younger people, I think is an answer. And then the other is dealing with them in terms of, you're gonna hate this word. No, y'all probably won't. But sometimes the issue is deeper rooted than just getting this vaccine. It's so much systemic racism that's there that, they don't care what it is. They're still focused on, is this what this is? How does that impact? So we need to acknowledge and say, yes, it is, but it takes all of us and not just people of color to address this issue. This is a humanity issue. It takes all of us to do it and not just one group.
Yeah, and if I could just add, I truly agree with everything that's been said so far. I think the key is just ask them, let people come up with their own solutions. We provide information, they can ask questions, but I think we need to not be afraid to let them speak out, let them talk about what's wrong with society right now. Let them talk about their fears. This is, make it real. And when you go to them and empower them to talk to other people, I have a lot of confidence that, younger people today can find solutions, and they may do it very differently from we as professionals, but that's okay. It's their world, it's their community. And, sometimes I think you have to let go and let, trust that they'll figure out the right thing to do and let them teach us.
Absolutely. Thank you all. Our next question, how have the problems with the Johnson & Johnson vaccine been viewed by communities of color? This is a hot button, so I'll mute myself.
Well, it's not so much a hot button other than the fact that even for all of us in the country, maybe even around the world, we're walking gingerly as we're raising up our sleeve, and it doesn't take much to throw that off balance. But the biggest concern I have was when they were making the J&J available, and that's supposed to be the workhorse for the globe. We don't vaccinate the globe, the world, none of us are going to be safe. So when a physician I know who was very excited that they were getting 100+ doses of the J&J for delivery in their primary care practice with patients that they already know, patients who love them, she says to me, I wake up and it's Wolf Blitzer telling me that the J&J vaccine has been on pause. Why am I learning this on CNN? Why am I learning this the same time my patients are learning? She's in a panic. She's now used her trust, her credibility with her patient population, and now nobody's respected her enough to let her know in advance. Now, we can have all kinds of reasons of why it happened that way. I get it. But I want you to know that's how she felt. And nobody wants to be set up to have the rug pulled out from under them, because all the trust and credibility that the folks in these Hollywood squares have built over the decades, we're not going to lose it because of mistakes that others are making, short-sighted mistakes. And when mistakes are made, we need to find out where the accountability is. I live in Maryland, so it hurts me that the emergent plant in Baltimore, you know what I mean? I know, Lois, that's where you are. And we don't like to talk about those, but if we don't talk about it, that's what they're talking about in the barbershop. So if we come in and we don't talk about it, they say, well, they don't even know what's going on. We'll just be kind and shake our heads and then wait till they leave. You got to bring it real. And one last thing, all of our little medicine cabinets have been improved by electronic thermometers. We never had an electronic thermometer. A pulse oximeter. I never had a pulse oximeter in my house. But guess what? The pulse oximeters are not accurate on people with dark pigmentation. Who knew that? Okay. I don't want to walk in the barbershop and they're telling me, hey, Dr. T, did you know this doesn't work on us? I need to know that in advance. We need to take the industry to make this stuff work for us. Now, where's the Black entrepreneurs? Where's the minority med tech people? Okay. That's how I think then we got people who will listen to us. But if they think that we're in our own bubble and we don't know they're suffering, they'll nod their head and wait for us to leave. That's what I'm seeing.
Well, let me tell you what we did, because I was one of those skeptics about the one shot and saying, oh, you're going to give the vaccine with the lowest efficacy in the people of color in rural areas. Why are you doing that? You know, I was running my mouth before I had all the facts, but that's okay. That's how I got my facts.
That's right.
And when I got called in by the scientists at Johnson & Johnson of, okay, the efficacy is different, but we are the same in terms of keeping you out of the hospital and keeping you from dying. Okay, you may get COVID, but you won't be hospitalized or, and ventilated, or you will die. I said, well, that makes sense. That makes sense, because we all trying to stop the deaths and like that. But what we did was, so our patients won't feel that while you're doing this, we actually offer the patients, because we have Moderna, you want Moderna or you want Johnson & Johnson? When you give people a choice and then they ask you, well, what's the difference? And we're able to tell them, they're making a choice. It's not like they feel that, oh, you're experimenting on me or anything like that. So the one shot one that we decided to do is those patients that we know we will not get back for a second shot, like our homeless patients, like our migratory patients. If we know they won't make it for a second shot, and so that's what we use it on. But I found giving patients a choice, which eased me of, it's not like you pushing one thing on them. We've had very good response because a lot of them are choosing, I'd rather just do the one shot and don't come back.
Right. That's excellent. We are out of time, but I do want, Dr. Kusher had one comment he wanted to add here, and I wanted him to be able to chime in. Go ahead.
I think we've had a lot of challenges with the Johnson & Johnson, even though it was 1 in a million people that had the side effect. People don't look at it that way. And I think with good reason. There was already a lot of questions about Johnson & Johnson because of the issue with the fetal tissue, which have somewhat been debunked. But yet, once people have that doubt, you're not going to shake that out of their mind by shaking them. It ain't going to happen. And so we just have to recognize that that's what's happening. And it's going to take double the work in order to get people to take that vaccine, even though it is just one shot. And in some ways, it's a lot easier from a logistics standpoint and from people not having to take off a second day and getting sick all over again. But it's going to take us double the work in order to get people's confidence back in that vaccine.
Absolutely. Well, we are at time, and I just want to thank every single one of you, Dr. Kusher, Dr. Thomas, Dr. Whitley-Williams, Lathan Woodard, Lois Privor-Dumm. Thank you so much for joining us today. This has been an excellent and robust discussion, and hopefully for our audience members, we have provided you with some recommendations and some solutions, that you can take back to your communities. And with that, I will sign off. You guys have a wonderful, wonderful day.
Bye-bye.
Bye.
Be
Bye.
safe out
Thank
there.
you so much.
Wear your mask, wash your hands, and stay away from
That's right.
crowds.
Social distance.